Welcome back, everyone. My intervention will be very short. I would just like to introduce the moderator of this next and last plenary of this EHMA Conference 2024, a plenary named Innovating Service Delivery, the Challenge of Transformation. And it will be moderated by Dr. Matthias Wismar, Program Manager at the European Observatory on Health Systems and Policies. Matthias, you have the floor.
Thank you so much, Theodore, for this very kind introduction. I think that the title of this plenary session, Innovating Service Delivery, the Challenge of Transformation, fits very well the bill of this conference, actually, Innovating Service, that we talking about innovation and their ecosystems. And the background here is actually that we all know we need to transform. And transform means not just incremental change. We need to go a bigger step. We need to have the digital transformation. We need to transform towards primary health care. We want to align our health workforce with all these changes and transform the health workforce. We all know that we have big challenges ahead of us, like, for example, climate change, and we need to transform for sustainability. And we see a lot of movements into this direction, but at the same time, all too often, we feel we get stuck in the midway. And the transformation is not really going forward, even though we know exactly what needs to be done. We know the intervention. There's enough evidence on the intervention effectiveness, but we don't get this intervention in the system, or at least not in a way that it really works very well. And this is a theme today of the workshop. We want to discuss how do we get the innovations actually into the system? How can we manage the transformation? And we have a great panel. We have Joseph Figueras, that's me. We have Joseph Figueras, the director of the observatory, who will give us a little bit of a keynote, a kind of conceptual framework to think about transformation, innovation, and the implementation of innovation. And then we have wonderful speakers. We have Jean, a well-renowned professor and a regular of the EHMA conference. I think we have met here for the first time, actually, years and years and years ago. And we have Catherine from France, from the Public Health School in Rennes. And they come up actually with elements and experiences and particular models, supporting transformation. Before we start with Joseph's keynote, we would like to have a little poll. Yes, it works. Can you hide the percentages? Please scan. There are 3 questions coming in a row. First 2 ones are just yes and no. Is the health system in your country undergoing a transformative process? Yes, one says. So the optimism prevails, the positive experience is there. It's probably sluggish, too slow, and not as inspiring as you hope. But apparently many people in the room can relate to transformative processes in their country. However, we have at the moment with 52 people voting, almost 20% of people say, no, my health system is not moving. You could positively say it's stable, but probably it's just lagging behind. Next question, please. Can we have the next slide? And the next slide refers to audience involvement, because when we have the question time, we don't want to have just comments from your side. We want your experience, your first-hand experience. Are you involved in the transformation of your country's health system? And this is an early warning. So later when we discuss, please think about an example from your own work life, from your own country, from your health system, where you have a transformative experience. Now you can reveal the percentages. 60% of the colleagues in the room have some experience, actually, and we are very keen to hear about this. And the discussion, the conceptual framework we will present, hopefully inspires you to bring this on board. And now the last slide. I can't believe this is flying. Last slide, please. So what are, in your experience, the 3 most important facilitators of health systems transformation? Political leadership, people that go forward. like we've seen here in Romania with the minister who is there for this health system strategy, for the health workforce strategy, who aligns with it 100%. Ensuring sufficient resources for these transformative processes, that you really can conduct it. You have the resources in the ministry, you can develop a plan, you can execute it, you have the money to implement it. A clear vision and strategy for change. And talking about health workforce earlier today, many countries don't have a health workforce strategy. Not at all. It's not clear what they are going to do, but it's very essential, actually. And then a governance that adapts and aligns with change. We are always working in the old governance, in the structures which we have inherited, and we want to have new forms of service delivery, like, for example, primary care, and clearly the governance needs to adapt it. We cannot stay with the old one. Commitment is absolutely needed, and of course, well-resourced and aligned local level, and I can't emphasize it enough that we not only need the top-down, but we need also the bottom-up at the same time. And what is also needed, is the stamina, because it's not a one-off, it's a long process, usually. Now, can you reveal the percentages? A clear vision and strategy for change is the winner of today. A governance that adapts to and aligns with change, ensuring sufficient resources and political leadership. And stamina probably very, very low. Joseph, can you relate to this? Have I stolen your thunder? Please, Joseph, the floor is all yours.
Thank you. Thanks very much. That really helps a lot, Matthias. If you could put the first slide, please. That helps a lot, Matthias, because indeed, what I wanted to do in the next few minutes is to, if the click works, sorry to be back here today again with the same problems of clicking, but this time we've been rehearsing. Yay, great. So here we are. So the idea, what I wanted to do today, and I hope it's helpful, importantly for the debate we want to have later on with your own experiences of our colleagues on the stage and your own experience, is the idea of transforming health service delivery. What are the key factors? And this idea of implementing organizational and technological innovation. I'll be arguing in a minute that actually a lot of our literature, a lot of our work, a lot of our analysis has moved from introducing, implementing, scaling up innovation to a much broader phenomena, which is changing your health system, changing your system delivery. When you look at the actual strategies, these two fields of literature and work come together. Health systems are complex systems to transform, and they are embedded in even more complex systems. I know you know, but it's a good reminder. When we talk about transformation, we need to remind ourselves that this is indeed a complex system we have to play with and embedded in much more complex systems. Even Donald Trump got it. Nobody knew healthcare could be so complicated. It is complicated. If Donald Trump realized, we should realize it as well. I repeat this slide, I'm sorry, from those of you who were in our masterclass on knowledge brokering, because in some ways, helps me a lot in this presentation as well. Health systems are complex, systems to transform, we agree. And the process of change is often not that rational. And we all dream about this beautiful circle here, right? Sort of agenda setting, formulation, legitimization, legislation, allocation, implementation, evaluation, and back again. The reality is actually far different. It's a much more complex reality. So when you have to transform, we like to fall into these very nice frameworks, reality is much more difficult. And yet, we need to continue trying. So somehow, after having argued that it's all very messy, I will try to put forward a framework that has been led by Dimi Pantelli, one of our colleagues at the Observatory, and her colleagues. And also these two slides actually is an interesting, these two publications are 5 years apart of the two ministerial conferences in Tallinn. I had the pleasure to edit both of them. And the first was very much of this emphasis about introducing innovation, implementing innovation, and now reflects as well the shift of the work of the observatory in this broader phenomena of transforming health service delivery. So, the question that is going to be permeating through my first part of my presentation, which is around this framework, is what can policymakers do to drive transformation? And I'm warning you, so don't complain, I am taking a top-down approach, because then I hope in the discussion and our colleagues will take much a bottom-up. And as you can see, I clearly acknowledge the importance of both levels, at both level and national level, and my focus of my presentation is going to be the policymakers with whom we work. So leadership in the health system at what level? National level, healthcare organizations, leaders, planners, policymakers, at local level, managers, administrators, clinics, and so on. And we'll be talking about the kinds of strategies to drive transformation at the top level. And highlighting the complexity, and complex systems are particularly rigid and resistant to top-down challenges. So I'm very much aware of that. So we need to find, as has been said ad nauseam, and particularly EHMA, is top-down, bottom-up. So the basics. So I'm giving you the short message that you all know. So it's not rocket science, I'm sorry, but still maybe it's worth reminding ourselves. The basics are all about leadership and resources, and you reflected that, well, not quite entirely actually. It wasn't leadership what came first, right? What came first, Matthias? We don't remember already. A plan. Okay. So a plan. Let me give you the basics. Transformation, to transform delivery at top level is all about the right conditions in which transformation will flourish. Foster the health system's willingness and ability to change. So these two elements for me, for the literature, for what I've been looking at, are fundamental. The leadership involving the political will, the clear vision and strategy, so I have the plan in there, we got it right, and which is all about shared commitment, it's all about clear and transparent targets, it's all about aligning governance, which came very clear on your board. It's one of the most important things in reforms, aligning the various levels of governance. We learned an awful lot during COVID about aligning governance for the better and for the worse. And sufficient resources, as always, to be able to enable that change. Money, people, technology, and information. Again, I am truly humble in presenting that because I know it is not rocket science. You all know about that. I'm just wondering how much when we do that, we go through these stages and think about the kinds of innovation mechanisms we can use in these stages. Problem identification, a strategy for change, regulation, resources, implementation, and not least, at the very center, the leadership and the political will. So let's say a tiny bit in each one of these circles that you know about, but are still worth reminding ourselves. In problem identification, we learn at particularly national level that performance assessment, benchmarking, naming and shaming is a good way to go about. Country comparisons, but not only that, of course, lots of surveys and consultations with the key actors will be very important. In terms of a strategy for change, I think we can be much more sophisticated there in many countries, in many instances, horizon scanning, pilots without falling into that disease of pilotitis. So you keep piloting, and nothing ever changes. Innovation funds, the use of innovation funds, countries like Finland, for instance, have very, very innovative experience about using funds to enable change and compare best practices. And the regulation, of course, will hear in 3 examples I give at the second part of my presentation, the importance of payment mechanisms, training standards, data governance. You know about all that. But do we really put it together when we're doing change? Do we understand the role that these various mechanisms and innovations in terms of change, I'm talking, innovations in terms of producing change, are being used? The resources we talked about, sufficient resources, financial, but also considering human as resources, technology, evidence, supporting data, and finally, of course, implementing and monitoring. And there are many ways there. Actually, one of the areas that we find very helpful in the observatory is working with networks and knowledge and change. It's really these communities of practice, bringing together various hospitals, for instance, undertaking a reform, bringing them together, exchanging experiences with them at the leadership, and trying to enable this process of exchange is one of the areas that is very, very effective. But here in the room, I'm sure you know much more. So these are the key actions. And of course, as any beautiful circle, transformation entails continuous learning and adaptation. So you don't go just around the circle, as we all like to see, but then you go to different stages to reconcile, to change incentives, and so on. Okay, so far, so good. Not much new, I know. And maybe that's not new either. But what about that leadership? What about that phenomenon of leadership and political will? We always like to talk about leadership and political will. And in this room, you know an awful lot. But still, what do we mean by that? It's the political economy, stupid. Okay? Many of you, perhaps some of you, you're not laughing, I'm worried, I'm not calling you stupid. Not Hillary. Bill Clinton had in his post-campaign very big label saying, it's the economy, stupid. So he keep reminding himself. So I like to do that to you today. It's the political economy, stupid. How good we are in understanding and acting on the political economy of change and transformation. I find a very interesting phenomenon working with politicians who are made genetically and trained to be aware of the politics. Sometimes they cannot go through these stages systematically about stakeholders, mapping different stakeholders, influencing stakeholders. If I had time, I would love to discuss a number of strategies, kind of Machiavellic, but very useful strategies, like recruiting new players, like decreasing power of certain of the players. Take, for instance, in a country whose name I just forgotten, introducing primary healthcare in that country, the strategy there was to bring the new GPs on board and try to give them more power and visibility and confront them with the old GPs that didn't want to have any change. That's just straightforward, isn't it? Shouldn't we use it more? What about steering public perception? Say, look at what the doctors want. It's incredible. It's not okay. So you confront different actors. Windows of opportunity. In our masterclass, we're talking about is perhaps the most important element. Find the moment in which you can have. My theory on that is you do incremental change. You know the famous theory for hundreds of years, should we go incremental or big bang? Okay. My view in that is always incremental, and then when you have a window, people don't pay attention, you have really a good basis of political support, boom, big bang. Small big bangs under incrementation. And of course, clear, tailored, two-way communication. I said that already many times, but if there are 3 lessons, you know that is communicate, communicate, and communicate. And I said already too many times that during COVID, that was probably the key most important strategy during COVID times. And here, people like you don't need to hear much about that, because you know about that. It's how at the beginning you engage the right people, how you engage the champions, and how do you create strong targeted messages. Pretty straightforward. But it's important is sustaining interest, and particularly to bring those best practices ahead. So highlight those individuals that are doing particularly well. So there's a lot there that we could be talking about in terms of communication. I move now to the second part of my presentation, which is giving you some illustrations, more specific illustrations, where we'll see some of these elements playing a role. One is integrating healthcare delivery. What are the key levers? Skill mix innovations in primary healthcare, about how we implement them. They're really flashes to get you inspired, I hope, with all due humility, to then think about your own experiences you want to share. And I cannot avoid being about innovation. How do we harness the promise of technological innovation? That's a bit silly because the whole conference has been about that. So me pretending in 2 slides, I'll give you anything good, but I'll try at least to add something of the wonderful, incredible, useful things we've heard these 3 days. First one, integrating healthcare delivery. What are the key levels for transformation? Listen, colleagues, I'm just exhausted. I'm exhausted to go to different countries. I hear, well, this is this model of integration, the nurses are in charge, this is the GPs, this is a model which is decentralized, re-centralized. No. It's all fine. It's all evidence. It's all context specific. What we need to focus regardless of the model, I know what I'm saying is not rocket science, but please, listen to me even if it's not rocket science. Doesn't matter of the model. What matters is the ability to engage the various stakeholders, the various professions that will be in integrated healthcare delivery. The real problem in integrated healthcare delivery is the leadership is very fragmented, with different groups pushing their own professional objectives or their own vested interests, like in many other reforms, by the way. The digital. How can you have an integrated care delivery when you don't have e-health records that they're connecting? Now, rocket science, I know it. But there's no chance whatever model you put in place. Payment. There's a lot of emphasis on payment integrated care delivery, and actually we realize that there are many, many important limits on paying for integrated care. Because actually, and the next point here is about patient-centeredness, and actually we should be tailoring these programs for individual patients, and we need to be better trained at that. Continuous monitoring, and 2 points that I'll take forward in my next set of reflections around the health workforce. A multidisciplinary team and the new roles and competencies. How many cases, how many countries whose names I will not be mentioned because I don't think one should name and shame, many important integrated care delivery reforms bringing to the community and so on have failed because not enough nurses. Yeah, that's it. Not enough trained professional. The models were, in that particular case I'm talking about, absolutely great, highly published. Everyone loves the model. It hasn't been implemented because there's no staff. And when there's a staff, the roles and competencies of this staff are not very clear. I like to highlight here, again, still from the broader level, the work plan of the WH European region on the health workforce, which actually brings you a beautiful example. It's not up to me to present it. Actually, I think I have Thomas Tapata, colleagues from the team. And it's exactly a very, very good case study, a good example of how you focus on the elements in the training, on the investment, the kinds of investments you need, the kinds of training that you need, the kinds of skill mix and funding that you will require, the kinds of plans and strategies to enable that. So that's, I think, a very good example that thinks about health workforce in terms of transformation, rather than entering into the details of those policies. I will, in my second part, remember I started about what policymakers should do to transform. I gave you a framework, shopping list, a checklist to think through. That I hope it helps. Then what I'm doing now is I'm taking 3 examples. I mentioned already integrated care delivery. Now I like to say a tiny bit about health workforce, presenting and highlighting this work plan, and then talking about a particular area that is key in the performance on the health workforce, which is redefining teams and a skill mix. This is one of the studies that my colleague Matthias Wismar, Gemma Williams, and others have been working on within the observatory, which is, and with our colleagues in WHO, which is about identifying the kinds of skill mix changes that we know are cost-effective and value for money. So in this particular study, they identified 6 of those around task and reallocation shifting, supplementary roles, teamwork, and collaboration. So I will not go those in detail. Obviously, that would be a part of the whole plenary, if not a conference. But we see here elements such as the role of pharmaceuticals in chronic prescribing, nurse-led clinics, hospital at home, case managers and patient navigators, different teams, and so on and so forth. So the evidence is very, very strong. And it's been strong for many, many, many years. So why is implementation so sluggish? What are we doing wrong? How many EHMA conferences have been in many of these skill mix? We ourselves in the Observatory had the privilege to share some of that with you colleagues. This volume, this particular study I was mentioning, actually focused on the implementation. And is the political economy stupid? Yeah? Professional acceptability and cultures are one of the most important phenomenon that explains the complexities of having nurses taking leading roles. But there are others, of course, in our checklist, such appropriate regulatory framework so they are protected, reform training, or having the right incentives. Of course. But why is it that many say nurse prescribing for chronic care is no rocket science? Sorry to keep repeating that word, it's boring. It is really nothing new. They are particularly good, the nursing profession, on following chronic care patients and in prevention. Why it's not happening systematically? It's happening in some of your countries, I do know that. But why is not happening systematically when we have a problem to recruit and retain the medical profession as well? And that's my last part, which is how to harness the promise of technological innovation. Ultimately, talking with Gemma Williams just now over coffee, what we're talking as aging is the major disease. It's aging we need to tackle to avoid or to address the other diseases, the cardiovasculars and cancers. So my focus here, surprise, surprise, is the promise of technological innovation has to do with our ability to adopt, introduce, and embed innovation. And let me give you just one example on AI that is all in our minds, and particularly after this excellent conference, which is the pace of innovation of AI. This is the pace of innovation. I was just at another conference talking to technology experts from a very big company whose name I will forget again. And they were showing me how they developed this AI that stays with you in the consultation, keeps recording what's going on, and automatically goes into the electronic record of the patient or the links. But not only that, goes into the recent cases of Johns Hopkins on that particular lymphoma. Guidelines, of course, now, when you publish them, they're gone, they're all. So that machine continues listening and providing hints to the doctor, saying you should ask that now, then you have 80% of being that, 70% of that, and well, keeps increasing the probability. The next question was, well, when do we get rid of the middleman? The doctor, the middle woman. They said, no, of course not. The doctor is very important. No. After a few drinks and an hour discussing, they said, yes, a couple of years. Okay? I don't believe that, or I believe that. I don't know. What happens is, I'm one of these stakeholders that is a tiny bit more aware, but I'm very far from there. What really worries me is that the evaluation regulation efforts are really flat. I had the opportunity over the years to be in several meetings with the chief medical officers of the European Union. During the Finnish presidency, we talked about the complexities of regulating the unknown, the genomics. It's the same with AI. And colleagues, I'm not asking regulate to restrict. I'm talking about regulate to enable. I'm not worried that that particular technology will be accessed on the web for me and my kids. What I'm worried about is whether a vested interest. I'm not worried about the algorithms of the AI. I'm worried that there's a vested interest of pharmaceutical industry or there's vested interest that are actually manipulating what is the best option and treatment. So to me, if we're talking about technology, we're talking about AI, that's the most important element. The fast change, we already lost the train, and the uncertainty behind it. And finally, I'm going to finish with, from very sophisticated technology to telemedicine. GP consultations are a telephone. Truly, just a telephone. And we had telephones for a while, right? And during COVID, we saw an increase in the use. I know this example you all know, but I'd like you to remember, you to remind yourselves again, with your permission. You see that increase during COVID. But there's another interesting thing here. What are the two countries that are at the bottom? Are they the best? Interesting. Okay, France and Germany. Bulgaria. Why? Because they are poor countries, they don't have technology, of course. They don't have training possibilities. What is it? Why? Okay, go ahead. People payment. Okay, that's one. What else? Exactly. This is what we did during the pandemic, and we did a study about the use of digital tools. And guess what? It's payment. The payments changed very quickly. So all of a sudden, they were paid to pick up the phone, right? and they had Wi-Fi as well for the computer that was working. So quality, guidelines, regulations, deregulating and regulating very quickly. We had the opportunity to work with some countries on that. It wasn't the technology stupid. It was the enabling factors that were no rocket science, and particularly digital health literacy and culture. Is it? You may want to say that when we come to discussion, you'll have a microphone then. Is it because the culture of medical doctors in France and la médecine libérale or Germany are rather afraid of being digitalized and being monitored? I don't know. Just say, I don't have a clue. But could culture be an important element as well? So how is the future looking like? How to harness the progress of technology innovation? Well, it may be fun, because actually the biggest innovation in future would be the scarce and expensive human resources. So we may want to think about, as Baumol said, the healthcare industry is very much based on human resources. Rather than conclusions, because I've been really too long, I think Jean-Claude Juncker, a younger Jean-Claude Juncker, has the solution of it all. So when I asked Jean-Claude Juncker, I didn't ask that literally, really, but anyway, let's make it like that. Jean-Claude Juncker, what can policymakers do to drive transformation? He said, we all know what to do, but we don't know how to get re-elected once we have done it. That's the political economy, stupid. Thank you very much.
Thank you, Joseph, for this great presentation, and also for giving us a bit of a framework to discuss the transformation we all need. But, from your presentation, Joseph, I find it a little bit daunting because, the complexity, it's great, you have so many different facets to touch upon, to do for the change. But the challenges, they are coming so fast and they are coming more and more. Aren't we too slow, actually, Joseph?
I think we are very slow. I think we lost the train in many instances. I think we keep pretending that we're going to regulate. Some technical models actually have said we should have a moratorium on AI. I don't think it's possible. I think the industry very soon, actually it's interesting when you talk to them, they are ready to be steered because they want to make money. So we in the public or private sector, the users, can still play a role. We have a very short window of opportunity. But this pretends that, too early, and then too late. It's going to happen. It's too early, we're not ready, we're not regulating. But we all know that. It's just that we have a very short window of opportunity to work with them, to self-regulate, to regulate, to have some basis. I think the European Parliament sort of directive on that, legislation on that, is very much in the right direction, but it's still insufficient.
Joseph, thank you so much. One way to speed up the process is to strengthen actually our leaders, our healthcare leaders. And this is why we have asked Catherine to join our panel here. Catherine is from the Public Health School of Rennes, and she is actually training hospital managers, all the hospital managers that are working in public hospitals, plus additional healthcare leaders in your school. And I think a school like this, it's the greatest place to address transformation, to open perspectives, to give people ideas and thinking about, all the challenges Joseph was talking about, but also giving them at hand, the instruments they need to address them. Please.
Absolutely, you're right, Matthias. So actually, what can the National Public Health School do to drive transformation, and more important, as you said, to help managers and leaders to drive and to spread innovation in their structures. So at the very beginning, we had a very basic idea. We have decided. We decided that to drive transformation, to help managers and leaders, we have to transform ourselves and transform our training course. So we needed to be exemplary. So we plan training trainers to innovate, both in the content and topics on one hand, and on the other hand, in the method used. To be more clear, I will talk about experiences. First, on concerning the topics, sustainability, for example. We organize 2 workshops with gathering researchers and teachers, and we train them on how to become a hospital more sustainable. And for example, the topics of the workshops were on how to plan to build up a staff mobility plan, very concrete one, and to mix the urban policy and hospital sustainability.
So how they get to their workplace, without using too much cars and stuff like that.
Yeah, and how hospital can be incentive and help them to have more green mobility, or greener mobility. And on the other hand, we had training about how implementing a greener accounting, meaning which taking this greener accounting taking account, of course, investment, the cost of investment, and on the other hand, the impact of environment. For example, I'm going to buy a new technology, so I will ask, of course, how it will cost, but I will ask how it will impact of the environment at the same time.
That's very interesting. We had actually last year at the EHMA conference a panel on greening healthcare, and we had a colleague, it was Winfried, I think was his name. He was talking about the circular economy, and how complex it is to make purchasing decision, and that nobody in his hospital actually has this competence. Please, Sophie.
And the second topic is governance. Governance as a structure, because it's a very important topic on healthcare transformation, especially in France. So for currently, the governance of the structure is moving to a more collaborative decision-making process, especially between leaders and medical leaders and executive. So we decide to build up training courses about launching a new culture of management, more collaborative management between those two communities of actors, very important in the hospital running. And so they have to cope together in mixed groups, case studies. They have to share experience. They have to share debriefing. They have to share feedback. And they have to listen to each other and to understand what the other group mean, what the other group think about this issue. And on the methods, I would quote 3 methods. We launch cross-fertilization between research and practice. So we implement research in our training courses for hospital manager, for example, or for chief nurses. And we launch a lot of simulation, putting the trainees in situations taken of realities. And at the end, we are launching a lot of design thinking. We are launching a new state of mind and new tools. We are delivering new tools of design thinking to use them to help a launching project or management.
Catherine, thank you so much. I hear lots of stuff which really relates to what Joseph was saying with regards to leadership, but also vision, to have a clear vision about what is coming. And I found it also very interesting that you are training the governance at the change of the governance. So that's quite something.
It's a main topic in France.
What is your feedback once your trainees, your students are in the system and working in the hospitals? Do they feel, oh yeah, that has really helped me, and I can really move something? Or is the regular context, imposing on them to fall back into less ambitious practices?
It's easy for the executive and the medical leaders. It's it's more difficult for the middle management, and there is a generational gap. The young trainees, it's quite natural to talk and to cope with the doctors, for example, the junior doctors or the interns or the medical leaders. For the ancient generation, it's more hierarchical and more difficult to cope with the doctors. But on the very top level, it's quite natural because you can have an efficient governance of health structures without partnership between the medical leadership and the executive.
To me, it sounds like you are very progressive in terms of your training program and the elements.
We don't say that.
you give your students. But the question for me is also in parallel the system changing? Is it also changing?
Yeah. And I think a very important level of transformation I didn't mention here is patience. Patients, experts, patients, and patients are more and more involved, aware of the health system, aware of their role in a health system, and the role they have to have in the health system, and they're more and more involved. So yes, I think transformation is spreading for the moment.
Thank you so much, Catherine. We will get back to you later on this one. I would like to introduce now Jaume and ask you to take the floor. Jaume, you are a thought leader on digitalization, technology, innovation in so many various forms and functions. So please share with us some of your experience with regards to transformation.
Thank you. Transformation is difficult. Everybody knows that. There are studies that show that between 70 and 80% of the transformations fail, but we keep insisting on that. Now I discovered with Giuseppe what he did during the pandemic, which is to publish a volume, and I think most of us did the same. So we did a study of the Spanish national system and what changes were required to do it. And when doing that, we came up to the conclusion that we're very similar to what it has been published by different organizations in the last 25 years. So I agree that we all know what needs to be done. The problem is in doing. Now I understand why the politicians don't do that. With your last slide.
So you feel his presentation was rather threatening than encouraging.
Yeah. So the problem is that organizations by default are designed to be stable, not to be changing. So especially long-term organizations. A startup is designed for change, for quick changes. But as soon as you stabilize, the organizations like a stability. So they are reacting to change. Same way that when someone pushes you, your first reaction is to push back. Okay? So when you're pushed for a change, you're saying, no, I'm not. I'm staying. So organizations do the same thing. And when you look at the why people don't change, the main reason for me is that many people are happy with the situation as it is. So unless we come up with a much stronger dissatisfaction with what we have, we're not going to move to the change. So that's the first step. People are dissatisfied, but, we can live with that. There are few changes. Mostly, as you said, policymakers, politicians are probably unhappy, but not so unhappy that they want to promote these big changes. So that's the first one. The second one for the change to occur is to have an idea of where we are going. And the third one would be, okay, how do we get there? Giuseppe mentioned also that transformations are not rational. I think there's a nice volume by the Chip and Dan Heath, which are change model, which mentions that the changing is like moving an elephant from one place to another. You have the rider of the elephant, which is the logical, is the person who knows where I want to go. But don't forget that under that person there is a huge elephant that is the emotional part. And you can be all the logic that you want, but if the emotions don't follow you, you are never going to end there. So we have to understand the emotions of the change. And the third element there is, okay, we need to have a path. How are we going to get there? And help clear the path. Sometimes what we find is that in the stakeholders, there are some people who are cleaning the path, but some people that are creating barriers in the path to prevent the elephant from getting where you need to go. So that's why change is so difficult. And leadership, it's important. But leadership needs to be also agile in that sense. When we know where we go, it's very clear okay, let's go. Let's put the strategy. Let's follow the steps. Let's design the process. Let's go there. But in most cases, we don't know exactly what is the final solution, and we don't know exactly how we can go to get there. And in these circumstances, we need to have this agility, this iteration. And many organizations, for example, there's a large Spanish bank that moved into this agile process, and they started creating a small pilots, small groups, to go agile, to develop new applications in the agile route. And at one moment, they were shocked to discover that the bank was very agile, and the only ones that were not agile were the management board. Management board had not incorporated any level of agility. And it's difficult to get the organization to move unless you incorporate agility. And it's one thing is to do agile, the other one is to believe and to be agile.
Joe, can I ask you, are we always so clear about our objectives at the plan? I mean, we've heard here from Romania that they have a workforce strategy, for example, and a reform strategy. But very often we adopt technologies, just for the sake of the technology. That's my impression, and not for transforming healthcare, for example, or serving the patients.
Yeah, I think the main objective is to have a clear objective for shared by everybody. Well, there is a lot of work to be done before implementing anything and making sure that we all share the ultimate objective. And the ultimate objective for a health system is the health of the population. Then from there, we can then go back to see, all right, how do we achieve that? And one of the ways to get there is this path. But if you put the emphasis on the path that you want to implement rather than on the ultimate objective, you are going to create a lot of antibodies in the implementation. So the first step is the why. Why do we want to do that? Then the next steps will follow.
And you feel that sometimes we forget about the why.
Absolutely.
Yes. Okay, it seems actually very simple. And also, well, Joseph, you said it's not rocket science, but in reality, there's a lot of science behind it, because these are the conclusions coming from the analysis of the COVID-19 health system responses. These are conclusions coming from the implementation of care integration, and also from the health workforce. Actually, how do you feel about what Joe and Catherine said, Joseph?
I think it's I like you said, Jaume, that I was arguing that transformation is irrational. In fact, actually, what I'm saying is we need to acknowledge the irrationality of these processes, but keep insisting in our rationality. Yep. Because what I tried to do earlier was to say, look, this is a mess, and yet what I'm going to do is give you yet another rationality to guide through this. It's not to be naive, to be able to understand these elements. I think you echoed and added beautifully well.
I'm not saying it needs to be. You need the rationality, you need the logic, you need the objective, but don't forget that you have an elephant underneath.
Exactly, which is the rational mind.
Emotional, irrational.
But you see, the irrationality, Jaume, is there's all this literature that I think in this room, perhaps you do, I didn't in the past, we don't read enough about, which is psychological, behavioral economics, behavioral psychology, stoicism. I was talking about stoicism the other day. There are ways to understand. Some good thing we do in the observatory, Matthias, is when we do policy dialogues with senior policymakers, we start with their tacit knowledge. We start understanding their values. We start understanding the biases. It's not enough, Jaume, and we both agree to say, their values, their whatever. We need to assess them and be part of the equation and build on those rather than ignoring them. So we need to understand that emotionality, that irrationality. The elephant moves in ways that are unpredictable, but we can do much better to predict what the elephant is going to do under you.
Sure, and if even if we say that it doesn't look rational for most of the players in the system, not moving is a rational thing for them to do. So we need to understand their rationality, which if we don't, we'll never get them to move.
You know what some civil servants say in some organizations whose names I will forget? They say a saying in my country, which is, if you sit enough time outside your home, you'll see the coffin of your neighbor to pass. That means you come in manager, you come in minister, yes minister, I'll be here, you'll go in a couple of years, I'm not going to move. And now, I know it's very basic what I'm saying, I'm sure you, being a scientist, can transform that into mechanisms of change. How do we move those who spect outside doing nothing until say they see the death, obviously not the real death, but the political or professional death of their managers?
Well, you mentioned...
Thanks a lot.
Sorry.
You see the picture of Gemma on this screen, our colleague. She couldn't make it, unfortunately, because of changing travel schedules. But she wanted to talk about the health workforce and the transformation process we're actually witnessing at the moment. And it's a bit part here of it. It started more than a year ago here in Bucharest with the Bucharest Declaration on the health workforce. And Thomas Zapata has been extremely instrumental leading this on the technical side, bringing together almost all member states of WHO and here providing this sort of leadership. And not only a very important framework emerged from this and important reports, so much, all very important. But my impression is that this is going on. And actually, if you think about the Belgian presidency, where Hans Kluge has been involved again, the Belgians have put it on the table as a health workforce strategy, a European health workforce strategy. And this is very important because they kind of established a common understanding that we all have health workforce shortages. We all have skill gaps in Europe. We all have medical deserts where certain skills, certain professions, certain services cannot be delivered, And it's not just, that it's this country or that country. So of course, the severity differs from country to country, but you find it in all countries. And one of the reasons why you can find it in all countries is the underlying issue. And the underlying issue is the demography. So the health work, the citizens get older and older, and of course there will be more demand for health services and more need for health workers. But our health workers are also getting older and older. They will retire. In some countries, there will be a real wave of retirement, and we don't know how to replenish it. And it's getting even more complicated because the young cohorts from which we recruit new candidates for becoming medics, nurses, and so on, they are shrinking. So we are here really in this together. And the idea that we can compensate with recruiting from third country doesn't really fly. We have seen that it never works, at least not in the numbers. So we need to find something about it. We need to improve the performance of our health workforce and align it to new models of care. And the important thing about the leadership, why it's transformative, is we are converting a national problem into a European issue. And we are accepting it. And with this, we are saying, wait a minute, it's also actually a problem of the European labor market. It's a problem of the European labor market. We don't see where they come from. We don't see where they go from. We have a European labor market. The health professionals can move freely across between countries. But is it actually paying out for health systems? Is it really a good mobility for the professionals, for the patients, for the health systems? And we probably need to much better align this market. It's a European issue. But there's another element in it, which the Belgians have proposed as part of the European health workforce strategy. And this element is support tools from Europe. There are so many budgets. I was today in the morning in a presentation from Agenas, and they were talking about a 1.5 billion project on establishing a telemedicine platform. And the monies are coming from the Resilience and Recovery Facility, European money, that we should use much more of this European money, to fund implementation of our plans. And the third element, which the Belgians were actually suggesting, was to look at all legal framework in Europe and see whether they are really aligned with health systems and with the development of the health workforce in countries. And to me, this is a quite transformative process. Of course, still, most important stuff will happen in the individual member states, But this is something where you have to complement it with this European dimension. And you see, there's a lot of leadership, starting WHO, Romania, Belgium, but also all the other countries in the council which are discussing this. There's relative clarity, and it wasn't so easy, because the minister had ideas, and then it was discussed together with the Health Insurance Institute, with the ministry, with the cabinet, to be very clear what could be actually the added value. What should our plan be? We were all clear, yes, Europe should do something about it. What the heck should it actually do about it? Where does it has added value? Where can it really make a difference? And then they came up with these 3 elements and bring it together into a health workforce strategy. And they continued to work on it. And we hope this is going to be a transformation. We don't know yet whether it will be really included in the council conclusions. If there will be council conclusions, then it gives the European Commission a strong mandate to spend money on it and to act actually, which would be very, very welcome and would be very useful. It has consequences instantly for the implementation and transformation in countries. Maybe they don't call it in the end a health workforce strategy, because I heard some countries, they're worried, if Europe has a health workforce strategy, people will ask why we don't have one. So, but you see, this will have some positive repercussions because now countries are thinking about it, WHO is proposing here this model, this recruit, train, enhance performance, and so on. Europe is looking for it. They will probably in the end call it an action plan or something like this, as long as there is the money assigned. So this is, I think, also very important transformative process, and we are, in a way, part of it, and I think that this conference is also part of it, discussing many, many aspects here of the transformation we need, and also how Europe can support this. So that was Gemma's and my little contribution to the discussion of the transformation. And before we go to a final round, I would like to have your views. And as I said earlier, we want to go to the next level of audience engagement. So it's not about, I have a question, or yeah, that's my comment. We want to collect from you a couple of examples on the transformative processes in your country, something which is going on, even if it is sluggish, like Joseph said, incremental. But then the window of opportunity opens and we rush through it, So doesn't matter if it is incremental at the moment, but where do we have these processes? Let's give some positive input here. Who goes first? So many hands at the same time.
Thank you so much for the opportunity. I'll just explain our experience in CASAP, where we decided to empower the nurses. It was not a matter in that moment, that was 2006, that we didn't have enough doctors, as it's happening now. It was not a matter of efficiency because the salaries were lower. It was a matter of giving the population and the patients the allocated activity from professionals who might develop fully their attitudes, their knowledge, their skills, so they are eager to be trained, then take care of patients. That means they are relevant to the patients, and also the doctors may be relevant to the patients because they can do also the diagnosis and follow-up.
To put it into the wording of the conference, you changed the ecosystem so that the professional and job satisfaction has increased massively, and people were attracted again to the profession. Actually, we had yesterday a workshop on skill mix, and people were saying, "Oh, it's so difficult to implement. Oh my God, the doctors. Oh my God, this and that. And I don't know. It's really worth the bother." And then somebody from the Netherlands came and stood up and I don't know what you're talking about. It's quite insightful, but we have this since 20 years, and all the professions you're talking about are very popular professions in our country, and everybody wants to become a healthcare assistant.
Stereotypes. Next point.
This is a contribution around the notion of the importance of leadership and political will, and I'd like to move it forward to political skill and just refer you to some very recent research by Justin Waring and colleagues from Birmingham University around healthcare leadership for political astuteness, because you can have political will, but as we're seeing in the current UK general election, there's much political will and very little political astuteness being displayed. And so I wondered whether Catherine actually included that in her curriculum for training for the trainers. And just as an example, which is a bit like Tony's, which is historical. I know Tony Didier's outfit very well, CASAP. Absolutely fantastic example of any primary care ecosystem. Again, in primary care, we had a colleague who was feisty and actually knocked on the door of number 10 and actually argued for a complete change in terms of access targets for patients to see a GP way back. And for a short while it worked until general practice found workarounds, and it is no longer working.
What about having Niccolo Machiavelli in the training curriculums of our managers and doctors? More points, Matthias.
Thank you. A very interesting session. My contribution will be on one of the points that we had in the survey at the beginning, which is aligning the governance with the why, as Jaume was saying. And I'm also hinting that I was looking forward to see Jaume's answer to that question: how do you civil servants? And let me give you a very short story. You were giving Romania as an example of good practice in health workforce, which I think we are starting to be. But let me say this: it was easier to negotiate the Kazakhstan resolution for last year on health workforce than to do some very technical and concrete transformations with the people that work on the same floor with us, which are the civil servants. And one of the things that we used as a way to show them the why was that we took this international leadership, because we saw that, look, politically we have all the commitment, resources so, but there are some resources looking into this area, but we still do not get the technical people, the civil servants, to envision and to trust our why and our vision. So we had to, reverse and first get the leadership role, let's say internationally on the topic, promote it heavily in Romania, and get the people to work on this, because we are trying to get leadership internationally. So that's one thing. And with that, I'm curious at the end if there's time to see Jaume's response on how to engage with the civil servants, because that's a problem for us. Thank you.
Thank you so much. So politics is sometimes like playing pool billiard. You go not directly, but over the borders. Joseph, on your side?
Yes.
Thank you very much. So I would like to touch a point which was in a way or another addressed by each of the speakers earlier today. So about reminding who is the beneficiary of our work and of the healthcare system, and about the patient, in fact. And I'll give an example I used and I experienced myself as a manager of a health service provider, private health service provider during the COVID pandemic. We were serving a company with employees spread all over the country, the biggest company in Romania, actually, and we're talking about tens of thousands of employees. And we actually replaced almost immediately an occupational health service which incurred a visit in the clinics spread across the country with a phone call, as you mentioned. It was only a phone call to follow up on patients, split it to categories of risks for chronic diseases. And where I want to reach is not about the technical process, but about the empathy. So the value of the process was extremely well perceived in those times, because besides the health service, we passed the message of care to these patients. And this I wanted to point out. Maybe this empathy and reaching the patient with empathy can be an enabler of change in transforming the healthcare systems.
Back to you in that one later, Jaume. So basic empathy, emotions, and basic technology actually can get us very far. Matthias?
Transformative experience on my side. Please, give us something. It's not that late.
I cannot believe the 60% that voted that they had transformative experiences don't want to speak now. At least in this plenary, you cannot complain you're not contributing, because we want you to contribute. Any views? Any experience? Please, thank you. Buy your coffee later.
Thank you. Can I hold it? So I'm Matthijs van der Linden. I'm program leader of the Linean Initiative, which is a bottom-up learning community. So you talked a lot about healthcare transformation, right? And of course, it needs to be top-down, but it needs to be bottom-up as well. So have a all-stakeholder in the room approach combined with a bottom-up. And maybe you can give us some reflection about that as well.
I'd like to hear your reflections actually about having the policymakers talking to the doctors, to the chief executives, and so on. How does that work? How do you get them at ease and talking to each other?
So we've got some experiences, of course, with trying to bridge the bottom up or connect bottom up and top down. But I'm really, it's what's the word? It's a journey. It's a journey, and we are still figuring out how to do it the best way possible. We have a lot of contacts with the Ministry of Health in the Netherlands, with the National Healthcare Institute in the Netherlands, and we try to bring the knowledge from the workforce, from all domains like healthcare providers, healthcare insurance companies, industry, medtech, of course, patient organization, knowledge institutes, etc., and combine this knowledge and try to bridge or to connect with the policymakers.
Yes, indeed. I think sometimes it's about bringing these communities together without necessarily having great technologies, organizational mechanisms, but the possibility of having the dialogue in a safe environment. And it's the process as important as the outcome. It's something, Catherine, you were saying earlier about training. The training wasn't necessarily that you train people, but they train together. They work together. They create trust between them. And we're going back to one.
Your microphone.
Which is trust. Fundamental element in change and transformation is building this trust between actors.
We can have one more, Joseph, before we need to go back to the panel.
One sec, please. So if you want to learn more about the Linear Group, Linear Initiative, we will present it in a session after. So,
great advertisement. Well done.
Thank you. I'm Nicholas from France. Just wanted to share with you an example of transformation in the French healthcare system. My country just experienced the bundle payment, meaning that the pathway of care is being paid as a bundle now between the hospital and the care services afterwards. And we noticed that the hospitals volunteered to be part of this experiment didn't change anything in the way they operate usually after the bundle payment experiment was developed. And the reason why is because they already did the effort to change and to innovate before the experiment was developed. And the reason why they developed that transformation was the context they evolved in. And this context was competition. Because they were a hospital in a context that was very much competitive than others, and they were forced to change. And because they evolved in a competitive market, the leaders, the managers who were working in those hospitals were presumed to be the best managers. All right, so I just wanted to stress how transformation can happen just also because the context works fine. Competition definitely is a context that shapes the future.
That's a great story and very encouraging, and also, contrasts a little bit the results from the telemedicine, where there was not so much change. Yeah, let's get back to our panel. Quick reflection before we need to wrap up, and we have also a couple of minutes reserved for the new EHMA board, actually. John, can I start with you? You heard the colleagues and the...
Yeah. Well, I want to reflect on what you just said, because it is an interesting concept. It's another way to still look at change, which is we can have proactive change when we see an opportunity and we jump on the opportunity. We can have reactive change when it's no longer an opportunity, it's a survival. Either we do it or we disappear. From the logical point of view, the first one should be easier because we have more time, we don't have the pressure, but in reality it's not so. In reality, the changes occur mostly reactive when there is this external pressure. Okay, so when there's a crisis, we have a lot of these pressures to survive, to react, and there is a good opportunity to implement some changes there. Unfortunately, in many countries, I think we didn't use the COVID-19 crisis enough to get some of the changes that were needed. And we are slowly getting back to the previous normal, which should not be normal in that sense. Some hospitals have actually used that to start implementing some of the changes that they had in mind. I think it was credited to Churchill, the sentence of never let a crisis go to waste. But I actually found earlier on there was a medical doctor that applied that to a patient crisis and said, well, if this patient got a death or life crisis, it's a good opportunity to try to make a change in the lifestyle of these patients. It's a moment to impose.
So the window of opportunity, actually. Jean, thank you so much. Catherine, your reflections.
Just reflect to the point of my French colleague. Of course, competition drives faster to transformation. I do agree with that. But in addition, collaboration drives to transformation too. Partnerships is a very important level of transformation. Partnership between hospitals is really a part of transformation of our healthcare system, a very important one. The first point. We talk about emotions, and of course we have to deal with those emotions because they are relevant to drive transformation. We can't drive to transformation without taking account emotional, because they are here, of course. And trust, emotion are a part of trust. And my last point is driving to transformation of the healthcare system is not only a professional issue, but it's the issue of the patients too. I think it's very important.
Thank you so much, Catherine. Joseph, you've given us a very nice framework and a couple of examples, and then we heard here Catherine and John speaking, and we had a couple of interventions from the audience. Do you think we are making progress? Are we getting somewhere?
What do you want me to answer? Yes, I guess so. I guess, of course, we are moving. I mean, actually, it's very difficult to say anything clever after all the things you all said and trusting you heard. So I'm not going to come up with anything clever. But progress, we talk about all the organizational theories, mechanisms, incentives, processes. It's very interesting, Jaume and Catherine, that we sometimes somehow we're converging into the leaders. And one of the votes that no one voted for, stamina. I do believe that the stamina of the leaders, this ability to try and drive the elephant, Jaume, and this emotional intelligence of the leaders, and this idea that leaders are born and made, and perhaps we have to be a tiny bit better at selecting the leaders as well, and not only training them, but selecting those leaders that be able to run these transformation processes, number one. Number two, we all talk about the same thing these days, but I happen to believe in it, which is the co-production. I mean, the ability to bring people together. And the Dutch, of course, the Dutch are Dutch, and we're not all Dutch, and the problem not being all Dutch, we cannot act like the Dutch. The Dutch are able to talk to each other very well. It's the Polder model, the ability to share, to be transparent, to be open. And in some ways, we need to learn from the Dutch and other cultures about this co-production, this sharing, this debating, this transparency, and bringing the various stakeholders together. It's not rocket science, again, but perhaps if I had to conclude a couple of points, that would be my couple of points I would put on the table. Thank you, Matthias.
So going Dutch is the essence of our plenary today, Joseph. So thank you so much, everybody. And thank you so much for coming along and playing. And now, Federica, I think you planned something.
Thank you so much. We would like to introduce, first of all, thank our panelists. Thank you so much for this plenary. I would like to take the occasion to introduce a part of the new EHMA board, and I'm handing over to the 4 members who are here, and the 4th is already on the panel.
Thank you. Yes, apologies for this interruption, but we wanted to take advantage. Apologies also for not being able to wait till the conclusion, the concluenda. My name is Antonio Peris. I happen to be new EHMA president, and I'd like you to enjoy. I'd like you to be proud of being of EHMA. We want to listen to you, propose you not only a proper new conference next year, but many other activities, and for you to be enjoying also EHMA. Some of our colleagues cannot be here now because they already left. Marius Ungurianu, Esther Kovacs, Rui Satana, and Tiago Correia. But others are here.
You already know my name, so I'm Catherine Kerr. I'm the chair of Health Management Department in National Public Health School in France, and I just do agree with the proposals of our new president, and so I hope we make together an running EHMA with a successful him.
I'm Federica Morandi. I'm the Director of Academic Programs in Alpens, Catholic University, Italy. And very glad to serve in this new role and together with my colleagues to contribute to the future of EHMA. So thank you for this position.
Thank you, Federica. I'm Professor Todorka Kostadinova from the Medical University in Varna, Vice Rector for International Relations, Accreditation and International Projects. I have been part of the previous board, and I think that it will be our mission, also with Esther, that also was in the previous board, to achieve the balance and continuation in the new term of this board, and all together fulfill the mission of EHMA, to bring all the stakeholders together, to bring the knowledge, to bring the practice, to bring our visions together. Thank you.
Just to congratulate for a great Congress, and we expect later on will be explained for probably a great Congress too next year, and really thank the board, the previous board, has made a great effort and a great success for the organization, and thanks also for staff. That's all. Thank you.
Maybe it will be good to invite Professor Sandra Buttigieg as the previous president of EHMA, and I don't know how many of our colleagues from the previous board are here, but she is representing enough of the board, just to give our applause also for that, because EHMA is going together. Yes, again, on the last day, there are so many people traveling that from the previous board, only 2 are here. But I would like, first of all, to thank everyone for the support that we've had. I finished 6 years on the board, the last 2 as president, and I cannot thank my colleagues of the board that I was president of for the enormous work they've put in. And EHMA is a great organization. It is very relevant in healthcare management. I would also emphasize leadership as well. And indeed, I cannot thank my colleagues enough on the board, because we were a team and we had distributed leadership, because there's a lot of work to be done. And the important thing is that EHMA projects itself to actually what we do research on as an organization, to function in an ethical manner, to be an important organization and the leader in healthcare management and leadership, and to be the one to promote also to policymakers what is relevant in health systems. I would like to pass on the microphone
to my great colleague Anne Mahan from the United Kingdom. Indeed, it's a pity that there is no member on the boards from the United Kingdom, because we really enjoy the people from the UK to be part of this family. So, Anne. Thanks, Sandra. Thanks to members of the new board. I think we've got a great new board. I think I'd make 3 comments maybe as a former now member of the board of EHMA. I think first, and this is the context of really building on the strong position that EHMA is now in and really embracing the opportunities going forward. So I think the first is building on the real strengths of the Programme Directors Group. The second is really building closer and more effective relationships between the Secretariat and the board. And the third, as I think we've already talked about in the past couple of days, is building on the great successes of the amazing projects that EHMA is working on and balancing that with the commitment to EHMA as a membership organisation. And I feel really optimistic about how the new board will take on those opportunities. Thank you. Federico.
Yeah, I was still here. It's just because everyone is greetings, and I'm also stepping down after 6 years. I've been involved in EHMA since 1997, so it's quite a long time, and I'm still very happy to see that we're here after so many years, kicking our life and doing very well. So I'm very happy to congratulate the new boards, and I'm sure actually it will do great. And thanks to my colleagues for these last years together, and thanks to all of you for being with us in the last plenary session. So, the very best to you.
Dear colleagues, we have 2 previous presidents of EHMA and 1 director of PD Group. So thank you very much. I stay here and I come now here as vice president. Yes. This is a very good sign for continuation and stability. We have to build on. Thank you.
That's all. You have to work more. So, thank you, everyone. See you soon.